Hello, Dominic's shown you what the report contains and what the website can tell you about the year 2020, and there's obviously one big topic that dominated that year. And I'd like to show you how the report, the website, and you all responded to the year 2020. Though of course the website's far more up to date than the annual report and will give you information about what's happening this year, this month, this week and today for various aspects of your patient records. So to add to last year's report, which made some initial comments about 2020 as it developed, this year's report has a major focus on what happened. And if you want to find the report, you can download it from the website. You can download an enormous amount of other stuff, and alongside the report are a series of links, and within the report are numerous links taking you to files of additional information, graphics and details. One thing we ran during the course of last year was a facility survey trying to capture what was going on in individual hospitals at different stages during the COVID pandemic, to look at how hospitals were responding. All of the data for those is sitting on the website, and you would be able to download that as a file and make your own analyses and descriptions of what's happened in your unit and around the whole country. And ripping data off the website is something we would encourage. Back at the beginning of this year, Dominic and I were asked to write an editorial for the BJJ about COVID. And we did that not by going to secret files kept in the RCP, because there aren't any. Dominic and I don't have any access to data that you don't have. So all we had was what was already published on the website. And that's what we used to write the entirety of that editorial. So the NHFD is an enormous resource, and the more people use it, the happier we all are. The challenge of COVID when it arrived stimulated NHS England to bring out its guidance as to what people should be doing, how people should be responding. I'm not going to reiterate everything that happened at that time, but we all recognise that hip fracture is such a damaging and destructive condition, and so wonderfully responsive to good surgery and anaesthesia and medical care, that it remained a massive priority for orthopaedic surgery while everything else closed down. We were able to see the way in which things changed around the country, and you can see here there's a switch in the anaesthetic approach from general to spinal amidst the stresses on intensive care and anaesthetic specialties and the aerosol generating procedure concerns that were there right at the beginning of the pandemic. Spinals remain barely above generals now. But again, you can download additional information, all the dots on all of these graphs. If you just click on this, you can download all those dots, all that as an Excel file, and use it to do your own analyses for each hospital in the country if you're feeling keen. The NHFD responded very quickly to the pandemic's start, and we started logging patients' COVID status. We were right at that time. We were recording patients' COVID status with clinical diagnosis because testing wasn't universally available. That scoring system is now going to be simpler from January, since pretty much everything is going to be diagnosed on testing nowadays. But that meant we had data from the beginning of the pandemic, and over the course of last year we were able to map what was happening and to get a sense of the real catastrophe of COVID within patients in residential and nursing homes around the country. And we shared that information with NHS England, NHS Wales as the pandemic went on. It wasn't the same in each hospital, and you can see here that rates of patients being admitted with COVID when they first presented with a hip fracture varied quite considerably around the country. And obviously that's going to put an enormous challenge on hospitals in some areas where huge numbers of patients were coming in COVID positive. Much more common as a concern were patients who developed COVID during their time in hospital, and for them things were often very difficult, and the impact of nosocomial infection and wards being closed, entire wards being developing the infection, is something that I'm sure we will all remember to our dying day. One thing we've been able to do with that data, though, is to produce a COVID run chart, which we've kept behind the login, so it's available to all the clinical leads, and you can look to see what's going on in your hospital and other hospitals around the country. As you can see, the rates of COVID status being recorded came down very rapidly after we brought in the coding within the NHFD website, and as testing became more available. So with the majority of patients now, we have COVID status recorded, and that allows us to map how many people are free of COVID in the green line, or catch it in hospital, or develop it after they've had their surgery, which is the dark blue line, or present with COVID in the light blue line. And you can get a sense there of the two waves. Across the country, this is the shape of what happened. Considerably more patients developing COVID during their time in hospital after surgery than presenting with it. And you can download for your own hospital a pattern of exactly what goes on, and you can then look to see what happened in your hospital, the way in which care and performance changed over the course of the last year or two, reflected the pressures on you of the patients who came into you with COVID, or perhaps caught COVID during their time in hospital. As the pandemic ran through, we saw changes in staffing, and obviously at the beginning of the first wave, many geriatricians were redeployed to frontline medical activity at the expense of their work on trauma wards, and you can see a change in that on a national basis. That wasn't at all ubiquitous, and if you look at the facilities survey, the data there gives you a sense of quite how much that happened in different hospitals. Some hospitals managed to maintain all of their orthogeriatric support. Prompt surgery was something that really impressively was maintained. It's very difficult to get any sense of when the waves of the pandemic were affecting the hospital services. We really kept this going brilliantly, and I think it's something that we should all be very proud of. Physiotherapists, if anything, there's an improvement in the rates of getting people up post-op. Some hospitals had additional therapists available, redeployed from perhaps elective orthopaedic wards. But there's a real sense of urgency amongst patients and staff about trying to get people up and out of hospital and away from the dangers of hospital. So services were maintained, and that KPI was maintained. The rates of patients being clear of delirium changed in a slightly more complicated fashion. You can see that the dip of the first wave of the pandemic in the blue line of orthogeriatrician availability. But the delirium drop is a little bit more complicated than that. I perhaps should explain. In 2019, we made a change to how we were recording it, and instead of asking for 480 to be recorded within the first week, we brought it to the first 72 hours. To be more challenging and to make 480 a better measure of the quality of perioperative care than it had been. So at the beginning of 2020, there was a drop in KPI 4, and then the dip in avoidance and the quality of screening and management of delirium at the beginning of the pandemic then becomes an additional dip, and we're seeing things gradually creeping back to where they should have been now. Operations consistent with NICE recommendations. Well, I think that's a topic that is best left to Dominic. The surgical run chart, though, if we don't talk about what operation people had, but we just look at the people who didn't manage to get surgery, the surgical run chart showed an alarming tick up at the beginning of the pandemic. And we were concerned about that. The guidance from NHS England was quite clear that patients should not be deprived of surgical anaesthetic care, so that they shouldn't be going into conservative management pathways. But there was clearly something happening at the beginning of the pandemic, and at that point we were asking questions of whether hospitals were developing policies and perhaps diverting patients to conservative management pathways, or even suggesting that they might need not to come into hospital, or whether they were being diverted from one hospital to another. And that's a really complex picture to get to capture everything that was going on. But one thing we were able to do is this is a graph comparing all of the hospitals in the country, and as you can see, for the majority of the hospitals over the course of April 2020, everybody had surgery. But the rates of non-operative management in some hospitals were alarmingly high. And we challenged the staff in those hospitals to review what was going on and exactly what the decision-making process was for those so many patients being managed conservatively. In general, when the local teams went back and reviewed what they'd been doing, they remained comfortable that the decisions had been made appropriately and justifiably. One or two hospitals were more uncomfortable in their explanation of what had been going on. But over the course of the months, as you can see from the run chart at the top of the page, over the course of the months after that, things rapidly settled back to this normal position of all but 2% of patients receiving surgical management for hip fracture. We get about 1% of people who have perhaps an impacted fracture and just don't need surgery, and another 1% of patients who are being worked up for surgery but are so unwell that they die before they can get there. So we've re-achieved our normal 2% non-operative rate. If we want to capture the overall impact of the pandemic on hip fracture, we want to ask ourselves what the outcome was for patients. And this graph I find very reassuring. This is KPI 6. This is a key performance indicator driven by what patients want. And patients' concern is more about getting home than it is about mortality. And KPI 6, I think, is really important. It is, you need to remember, dependent on whether you're any good at doing follow-up to identify where people are at 4 months. And if you're only recording where people are sent on discharge, you may be missing some people who go to other forms of rehabilitation and eventually return home. So to perform well on KPI 6, you need to have good follow-up processes. But despite the disruption of audit processes and follow-up, we've managed to maintain a reasonably stable picture for KPI 6 across the country. That every one of these graphs exists for each of you for your own hospital. You should be looking at how your hospital's behaving, whether you've got back to re-establish your pre-COVID performance. Length of stay is part of that. And length of stay is obviously hugely important to the way in which the health service works and to the calculation of the impact of hip fracture on hospital services, bed occupancy and so on. The reason that we talk about mean length of stay when we're writing in the annual report rather than median length of stay is that mean length of stay rapidly can translate straight into the number of beds occupied in a hospital by patients with hip fracture. And I think that's a really helpful way of driving the resource implications of poor quality rehab services, poor quality surgical services, delays in the system leading to increased length of stay, and you can then directly calculate how many beds are occupied unnecessarily by patients with hip fracture. What we can see from this length of stay curve is that there's a huge impact for patients with COVID. Length of stay is very substantially higher for people who had COVID than for people who didn't have COVID. The graph, the dark blue graph of people who developed COVID post-op is perhaps a distortion of that in that people who are staying in hospital for prolonged periods because of pre-existing frailty are more likely to develop or pick up COVID during their time in hospital. So that's not necessarily a direct consequence of the COVID so much as the other way around. What is clear though, and the green line at the top and the two length of stay curves from the run chart, is that if you didn't get COVID, the implications of the pandemic were really very positive. The sense of urgency that developed amongst staff, amongst families, amongst community systems, the rehabilitation team, and as we've seen, the surgical theatre teams to get people through the system quickly and safely is really impressive. So if you didn't have COVID, your length of stay last year was very much better. And across the whole of the country, the overall picture for length of stay was a reduction in length of stay in parallel with the pandemic, something that's been maintained in many hospitals. And certainly my experience was of seeing people going home at a time point after hip fracture that I'd practically never seen in my career until then. The number of people I saw going home within a week of a hip fracture with intense, we were in 7 days a week doing ward rounds 7 days a week at the beginning of the first wave of the pandemic. But the number of people who seen by a geriatrician and a surgeon together on day one, had surgery, were up. The whole team was there day two. And the motivation in the patients, their family, and everybody to get them home was an eye-opener. And this means that the COVID pandemic's been a natural experiment in what might be achieved if everybody really pulled together. These patients who didn't have COVID had a really good outcome. And for mortality and the mortality picture, and I'm sure we all had horrible experiences looking after patients and wards of patients with coronavirus over the course of last year. The appalling tragedies that we faced were reflected in our overall mortality. These are 30-day mortality figures for the country, and you can see the shapes of the waves of the pandemic. I'm sorry that the COVID pressures on NHS Digital mean that we don't have more recent mortality figures, and we're desperate to get more up-to-date figures so that our mortality outlier support and our outlier monitoring run charts can be brought up to date. But you can see for the two waves of the pandemic that the impact on overall mortality was dramatic. However, if you didn't catch COVID, mortality last year was lower than it was the previous year. So again, there's a real sense that the urgency, the collaborative working that the pandemic brought to systems is something that we should try and bottle. We should try and preserve it. We should try and maintain some of those attitudes to try and do things that we never previously would have considered or thought possible, because they're getting people home, they're getting people home quicker, and they're getting people home alive who might otherwise have succumbed to more poorly coordinated and leisurely rehabilitation processes that we might have got used to in the days before the pandemic. And I can only say thank you on behalf of all of our patients and all of the staff in the NHFD for the efforts that people put in. I think it's a real testament to how much you all believe in what the NHFD is doing, that you were prepared to carry on putting data in on hip fracture when the world seemed to be falling apart around you. And I can only say thank you for that.